this is a banal lesion, the dermal nevus. And of course, this is a lesion that it's not exhibiting this reddish coloration, nothing else, comma vessels. Well, I'm not telling you that you have to remove all dermal nevus in your patients, of course. But consider that sometimes these lesions are difficult. This is dermal nevus. And now I want to share with you thin nodular melanomas. Why? Because it's very difficult to have thin nodular melanomas. And we had the opportunity to collect from different centers 10 cases that were thin melanomas, less than 1.3 millimeters Breslow thickness, very small lesions, all nodular melanomas with this dermoscopy. I will go into dermoscopy. And I have to tell you that these lesions were really very subtle under clinical point of view. In most cases, many were melanotic lesions. And on dermoscopy, they had a disorganized homogeneous pattern with some asymmetry in some cases, featureless pattern, and vessels. And vessels in this case is very important finding. This is the dermoscopy of these cases, but let's go to these results because it's important. In these very small nodular melanomas, very thin ones, half of the cases were detected by the doctor, not by the patient, because they were very small. Another important thing is that most of the patients had not a history of atypical mole syndrome, not many lesions. They were small lesions in the diameter, of course. Many of them were symmetric, few colors, not much information. But another interesting thing is that if you are dealing with early diagnosis of nodular melanoma, that is a big killer, and you tell your patients, okay, if you have a change in your mole, come to me fast, call me, you do this. But look at this paper. In this paper in the US, it's a different context probably, but you have to take this into consideration. It was significantly shorter, the waiting list for patients calling for toxinic botulinum toxin injection than for changing mole. If we are trying to do early diagnosis of thin melanomas that increase in few weeks from Breslow 1 to 3, this is challenging. And what about dermoscopy? Well, it's interesting to say that with dermoscopy we could detect these lesions, of course, yes, but this was important. Many of these lesions were not exhibiting what you expect to see in melanoma, in small melanomas. No pigment network, no radial streaming, strict pseudopods, no irregular blotches, no atypical dots and globules in general. These lesions were not exhibiting this. The key points by dermoscopy were a blue-white veil, these structuralist areas, and atypical vessels. Atypical vessels in these lesions, half part of these tumors were very hypopigmented, no much pigmentation in these tumors. So vessels were the critical point, and atypical vessels, all the combinations were found in these tumors. We are worried about false negatives and misdiagnosed because early diagnosis is very important. And we collected also in this paper a series in different centers of melanomas that were not clear melanomas by dermoscopy. And let's go that the differential in these nodular lesions, it's very wide. We have a lot of tumors that can be mimicking nodular melanoma. Melanocytic lesions, like this lesion in a young patient. This lesion was fast growing in 1 year, according to the patient, on the foot, dorsum of the foot, with this image. Well, with this you have to say it can be blue nevus, it can be, because of the history, a nodular melanoma, yes, could be. It was a blue nevus in the end, but fast-growing blue nevus. So we have a lot of differentials in nodular melanoma. And this lesion looking like very suspicious, very pigmented nodular tumor, can be nodular melanoma. Do you think this is nodular melanoma? What is your diagnosis in this case? BCC, pigmented BCC, yeah. Because vessels are in here, ulceration, well, it's more in favor of BCC. And this was BCC. But sometimes nodular melanoma can mimic vessels of BCC. Look at this lesion. Your clinical diagnosis is now BCC. Dermoscopy? Yeah, BCC. This is BCC. Sometimes this is another tumor. What do you think? BCC, I have to say this is BCC. And by dermoscopy, arborizing vessels, BCC. This was nodular melanoma. So be aware, because sometimes very few cases of nodular melanoma can mimic BCC, okay? So always remove this lesion. If you remove these lesions, it's not a problem, but this is really a challenging case. The same case, it's BCC under dermoscopy. This is the exception to the rule, yeah? We have different nodular lesions, of course, in our patients and tumoral lesions. And this is a squamous cell carcinoma. I will go very fast because Dr. Puig will tell you more about squamous cell carcinoma with this strawberry pattern in squamous cell carcinoma. This is in favor of squamous cell carcinoma and different of what you expect to see in nodular melanoma, of course. We have another challenging situation in clinics, that is vascular lesions, because these lesions can mimic nodular melanoma and vice versa. And you have to consider this dermoscopy and this situation and do very good job. Because sometimes melanoma can mimic vascular lesions, can mimic hemangioma, and we could find some cases with this situation. This is an example of a case that, of course, is clinically very suspicious, but if you go into dermoscopy, this could be lagoons, but not. They are not lagoons. Why? Because they have vessels inside. So it's completely different, this image, to what we expect in a vascular lesion, an hemangioma. But if you are not an expert, you can miss sometimes very small lesions in this situation. Nodular tumor in malignant melanoma, a very thick one. So remember, vascular lesions are never looking like this in dermoscopy. Never, you never can find these vessels inside. This is an hemangioma, of course, very easy. Vessels, again, vessels. Diagnosis, what do you think about this nodular lesion? Granuloma pyogenico, yes. And this one, what do you think? This is the frontal part of the skin of a patient. Could be many things, BCC, okay. Dermoscopy. Oh, sorry, life is not easy. This is a tumor that could be many things, but in the end was a pyogenic granuloma, okay? Very strange one, ulcerated, okay, it's fine. But pyogenic granuloma can be very difficult and can mimic melanoma and vice versa. Nodular melanoma can mimic pyogenic granuloma. Let's go inside. We had the opportunity to collect cases and review the dermoscopy of pyogenic granuloma, and dermoscopy is helping you because we could describe these findings, these red whitish homogeneous areas that were very frequent in pyogenic granuloma. Also, this white collarette in the lesion, my dermoscopy. These lesions many times are ulcerated with crusts and white lines that intersect the lesion. But pyogenic granuloma has many faces. And some of these images are very similar of what you expect to see in nodular melanoma sometimes, in a melanotic nodular melanoma. So we have to go inside. And we could collect more cases of pyogenic granuloma. And I want to share with you that most important finding that could help us is when you have pyogenic granuloma with that pattern. But sometimes pyogenic granuloma can exhibit also vascular structures, vessels, and many times atypical vessels. If you have this situation, you always have to remove these lesions because you cannot say that this is not nodular melanoma. Vascular vessels. Okay? There are cases of pyogenic granuloma. And remember, vessels are very frequent in pyogenic granuloma by dermoscopy, 45%. So please remove always these lesions when you are not 100% that they are pyogenic granuloma by clinical point of view, by dermoscopic point of view, because this is malignant melanoma exhibiting also very similar findings of what we expect to see under dermoscopy, and this is a very big nodular melanoma.